Morning, friends. Welcome back to my YouTube channel, Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe my channel and also please give your valuable comments. So, as we know, in the last class we are discussing about approach to a child with the cough, and we have already seen some of the basic information, and we have seen that cough is basically a symptom of the airway, and when the severe cough is there, it suggests that the disease pathology is still there in the airway. And as it enters into the parenchymal area, usually the cough intensity will reduce. And we have also seen how we can differentiate between the viral cough and as well as bacterial cough and also allergic cough. So in this class, we will have the continued portion of the same thing. Now, when a patient comes with a cough, and what is the major anatomy that you think? Now, do you think cough is only related to the respiratory system? No. Cough is primarily a symptom of the respiratory system. But cough may be also there in the cardiac system pathologies. Cough may be there also in of neurological system pathology, and cough may be there also in some of the psychological affliction. Now we need to understand this point very well. How to differentiate the cough of respiratory system and the cardiac system. The respiratory cough is most of the time without palpitation. If you see the cardiac involved, because of congenital cardiac defects are more common in children. Congenital cardiac disorders are quite common. Ventricular septal defect, atrial septal defect, and many things. Tetralogy, Fallot's tetralogy, triology, and all, and even rheumatic heart disease. So, a cough which is occurring because of the respiratory tract involvement, there will be a cough without any palpitation. Whereas, if you see the cough because of cardiac involvement, there will be a cough along with the palpitation, and also there will be a prominent over-functioning precordial area. You can see heartbeat, apex beat is very much dominant, predominant in the precordial area. But it is quite difficult in the children, isn't it? In the children or small kids, how they identify the palpitation. Palpitation usually it is very difficult to identify for the adults also. Now, what about the small kid? It is very difficult. Okay, so, but palpitation cannot be identified so easily in children, or children cannot say that. Child cannot say that I am having some palpitation like feeling. So always the over dominant or predominant or prominent over functioning precordial area should be seen. You just watch the anterior aspect of the chest in the left side area and see what about the cardiac activity. If the apex beat is very, very prominent and it is outbursting more, so then it suggests that probably there is ventricular overload, and as a result there is a cardiac problem, and that may be the cause for this particular cough. Now, cardiac cough, usually we will have tachypnea and distress is more than the cough. Another important thing to differentiate between the respiratory cough and cardiac cough is, in case of cardiac cough, the tachypnea and distress is more than the cough. In respiratory problem always, cough is a major symptom and all the other symptoms are less severe. Whereas in cardiac problem, you will have the tachypnea, predominant precordial area, and also distress. That is more compared to that of the cough. Cough will be little secondary. In respiratory cough, cough is more than the distress and tachypnea. This is how we have to differentiate. Tachypnea and distress is more in cardiac problem along with the cough, whereas tachypnea and distress will be less and cough is more in case of respiratory problems. When a patient comes with a cough, what the other anatomy that you think? One is okay, cardiac and respiratory. Apart from that, sometimes cough may be also because of GIT pathologies. Yes, mostly it is related to the food intake. Now, GIT means it is something definitely related to food intake. The two important causes which causes cough because of GIT causes are, one is gastroesophageal reflux disease and another one is achalasia cardia. Okay, so gastroesophageal reflux disease, the cardiac sphincter is not prominent, or there is no proper closing of the cardiac sphincter. So therefore, food which is mixed with the acid can reflux back into the esophagus, and that may lead to micro aspirations, and that leads to cough. This is a quite common phenomena of cough when the cause is from the GIT. But in all these cases, when the cough is there because of the GIT causes like GERD or gastroesophageal reflux disease, always the cough is related with the feeding. Either the patient says that after feeding the cough increases, or after while feeding the cough increases, such symptoms will be there, such presentations will be there. Okay. Another is cough may be also because of neurological problem. Okay, so neurological means cough center irritation. Cough center is present in the brain area. We know that medulla oblongata area. So suppose by one or the other cause, if there is irritation to the cough center, then it may reflexively lead to the cough. Of course, this cough will be a dry cough or hacking cough. Okay, now here there is no tachypnea, there is no distress, only cough will be there, and that cough will not be relieved by the normal the remedies for the cough suppressor. Okay, so that's one of the important thing in case of neurological. So we have to go for antitussive agents which suppress the cough by suppressing the cough center. Another cause where there will be cough because of neurological problem is, suppose if there is hypotonicity of the muscles, suppose muscles of the pharynx, muscles of the larynx, okay, oral cavity, so they play a major role in swallowing procedure. Okay, any neurological problem like lower motor neuron lesion or upper motor neuron lesion, that may lead to the hypotonia or hypertonia of these muscles, and that may create a problem in the swallowing, and there will be micro aspiration, and that may lead to cough. So these are the two important causes because of which neurological problems there will be cough. So if a child with tachypnea, then look at the chest retraction and the sound. This is very important. Suppose any child with a cough and tachypnea comes to you, then what is the first thing that you have to see is you have to look at the chest retractions. Now in the chest retractions, we will have three important retractions. One is suprasternal retractions, another one is subcostal retraction, and another one is intercostal retraction. The causes of all the three is different. Okay, now suprasternal retraction, that is in the sternal area, if it is there, then already suggests a obstruction to the upper airways, maybe in the trachea, maybe in the bronchial area, or maybe in the tracheobronchial juncture, or maybe in the larynx area. So then we will have a retractions of the suprasternal area. So when there is a problem in the alveoli area, okay, lung parenchyma or alveolar area, so then we will have subcostal retractions. Subcostal retractions will be there. But when the disease is there in between, in the middle, or interstitial lung disease, etc. condition, then we will have the intercostal recessions or retractions, intercostal retractions, as we seen in case of pulmonary obstructive, chronic pulmonary COPDs, chronic obstructive pulmonary disorders, etc. Okay, now for example, suprasternal retraction, there is obstruction in the upper part. For example, foreign body inhalation. Suppose the child has inhaled the foreign body and there will be a cough immediately, and you will have a retraction. That retraction is most commonly the suprasternal retraction. Whereas in case of pneumonia, etc. conditions, what we find is the subcostal retractions, involvement of the parenchyma. Okay, in other pulmonary disorders, chronic pulmonary disorders like bronchiectasis and bronchial asthma, then chronic pneumonia, etc. So we will have intercostal retraction. So that we have to understand. Now different sounds are there. For example, if the grunting is there, so grunting is there, usually it suggests the pneumonia. Grunting means by creating a positive pressure, we are trying to open the alveoli forcefully. This is a typical grunting sound. So in the newborn you can see. So when this type of sound is there, it suggests that the child is creating an extra pressure to open the collapsed alveoli forcefully. Okay, so grunting is always characteristic of pneumonia. Okay, pneumonia. Wheeze we know that's very typical of asthma. This is so wheeze is nothing but audible rhonchi. Audible rhonchi is called as wheeze. That's very typical of asthma. Stridor is from the upper airways, as we have seen in the last class. Stridor may be fixed, prior may be monophasic, biphasic. Okay, so that we have seen. If there is no voice at all, only coughing is there, there is no voice. Okay, that means patient is trying to cough, but there is no voice coming. So this is also possible when there is paralysis of the vocal cord. Suppose the pathology is something related to paralysis of the vocal cord. Okay, in spite of having all the cough mechanism and all those things, patient may not cough. Okay, although he is coughing, there is no sound coming. So this is another situation, even the paralysis of the vocal cord. So if none of them are there, okay, so patient is having tachypnea. Tachypnea with the grunt, we know pneumonia. Tachypnea with the wheeze, asthma. Tachypnea with the stridor, maybe laryngitis. Tachypnea without any sound even may be there in case of paralysis of vocal cord. But if none of them there, only tachypnea is there. Okay, patient is having only tachypnea. So only tachypnea without involvement of the respiratory system, without involvement of the cardiac system, etc. Then we should immediately think about a the metabolic problems. Okay, in a metabolic problem, it may be any conditions leading to disturbed metabolism. Even in case of fever, also metabolism is increased. Okay, so we have hyperventilation, so that may lead to tachypnea. Okay, or renal problems that may lead to the renal tubular acidosis like conditions, and acidosis may lead to some of the metabolic problems like diabetes mellitus, whereas diabetic ketoacidosis is there, or some simple electrolyte disturbances may also cause the metabolic problems, or sometimes inborn errors of metabolism, they may also lead to this. So any kind of metabolic problems, if they are prominent, then there will be only tachypnea. There is no respiratory distress. Okay, there is no cough, there is no breathlessness, nothing. Only tachypnea will be there. So when you find such patients, immediately you have to find out that yes, one or the other metabolic cause is there. Even we know that in case of fever, there is a increased temperature. How this temperature is increased? That is because of increased metabolic activity of the body. So metabolism has been increased, and that resulted in hyperventilation. Okay, in case of fever, hyperventilation will be there. So this is how we have to understand. Now, confirm the cough as the now clinical approach. What is the clinical approach? So first see, when patient comes to you, first see whether what is the main complaint of the patient or child. Okay, whether cough is the main complaint, whether fever is the main complaint, or whether breathlessness is the main complaint, or whether chest pain is the main complaint. This is very important because parents, they come, they can say multiple symptoms. My child is also having fever, my child is also having cough, he's also having nasal breathing, he's also having nasal obstruction. So they say multiple symptoms. Now you have to see which one is a chief complaint about that, above all. Okay, this is one thing you have to understand always. Always identify the main complaint of the patient. There may be multiple symptoms, but out of that multiple symptom, what is the main complaint? Number one. Number two, what is the age of the child? What is the age of the child? So whether it is early infancy, in late infancy, a toddler age. So this is very important. So if early infancy child and cough is the most severe problem, predominant problem. So in early infancy also, if there is a cough, then it's a serious disease, because actually talking, newborn and infant cannot cough, because cough is a very coordinated process. It is not so easy to coordinate. Okay, so the nervous system, etc., muscle system, nervous system, musculoskeletal system of the child, newborn or infant, is not so much matured, and it is not even coordinated. So it is not so easy for a child to coordinate a cough reflex. So if somebody says my 10 days old baby is coughing, it is not like that. It is some other voice which is coming from the respiratory tract, maybe because of thymus and all those things. It's not coughing. Okay, but really if the child is coughing in infancy, then it's very serious. Then it is a very serious disease. That we will see later. Okay, so one, you have to see the chief complaint or main complaint. Second one is you have to look at the age, clinical approach. Third one is origin. Whether this problem of the child is sudden onset or whether it's a gradual onset. Okay, sudden onset of the cough without fever. Suppose there is sudden onset of the cough is there, but there is no fever, without fever. Then the most commonly causes either allergy, because allergy comes very suddenly, immediately after exposure to the allergen, or it may be inhaled foreign body. It may be because of inhaled foreign body. There are only two causes where cough is very sudden. Cough is very sudden without fever, either allergic or either it is foreign body inhalation. Okay, now allergy may be with mild fever at times. Sometimes you can find the kids, actually they have got the allergy problem, but they also have mild fever. But although it is that, always the cough comes first, then comes the fever. Now if you see in the viral disorders, it is always the fever comes first, then comes the cough. Whereas in case of allergy disorders, always cough starts for 1 or 2 days, he is coughing, later he starts with a mild fever. So this is allergic. Okay, if it is viral, first there will be fever for 1 or 2 days, then the cough starts. So this is very typical differentiation. Now, so we have seen the chief complaint, we have to see age, you have to see origin, you have to see whether it's of gradual origin, sudden onset, etc. Suppose the cough is gradually coming, gradual onset with the mild fever, then definitely it is infection. Okay, now then you have to see the duration. Short duration of the cough. Suppose duration of the cough is very short. Okay, with fever, it may be acute infection. Long duration of the cough without fever or sometimes mild fever, Again, it is either allergic or any other chronic infections. Any other chronic infection. So this is very important thing. Now look at the progress. Progress. Okay. Persistent cough with the, suppose the cough is persistent. So then it is called as 100 days disease, pertussis. Okay. So usually in case of pertussis, the cough goes on worsening. Cough goes on worsening day by day. Okay. Then another is recurrent cough. So suppose if it is a recurrent cough, again, either recurrent cough is quite common in asthma or any other recurrent infections, recurrent viral infections, or recurrent allergics, etc. Now, very important is sudden appearance and sudden disappearance. Okay, so whenever a cough comes suddenly and suddenly disappears, that means today he has got the cough. Next day morning he don't have the cough. He's all right. Okay, no much cough or cough intensity is decreased or suddenly disappears. So sudden appearance and sudden disappearance, it is very typical of allergy. Very typical of allergy. Okay, you can find even the rashes. Today there is a rash, tomorrow there is no rash. Okay, within 24 hours it get vanished. So that's again allergic. Okay, similarly, cough is also there. Cough today he has got the cough, tomorrow don't cough. There is no cough. Okay, sudden appearance and sudden disappearance and sudden reappearance. Sudden appearance, sudden disappearance, sudden reappearance. After few days, again he start with the cough. That's a very typical of a allergy, hypersensitivity. Now, if there is sudden cough, but it does not disappear suddenly, what may be the cause? There is a sudden cough, but does not disappear suddenly. Now, it lasts longer. Today, he suddenly started with the cough. There is no fever. Suddenly, he started with the cough. There is no fever. But that cough is persisting. Since last 1 week, the cough is persisting. Now, this suggests that there may be inhalation. There is no fever. No fever. This suggests that there may be inhalation of the foreign body. Small foreign body has been inhaled, and that is causing the irritation. So sudden appearance, sudden disappearance, sudden reappearance, typical of hypersensitivity cough or allergic cough. Sudden appearance of the cough, again, in all these cases there is no fever. Sudden appearance of the cough, but not disappear suddenly, no fever. Okay, that's mostly some type of foreign body inhalation. So what we have to see is how to trace the non-infectious cough in the children. The cough when comes to children, first challenge is always we have to see whether it is infectious or non-infectious. Okay, because whenever fever comes, we have a doubt there is infection. In case of allergy, also there will be fever sometime, but mild fever. Okay, so how to identify the non-infectious cough in children? First, you have to see the onset. Then you have to ask the severity. Then you have to see the main complaint. These points we already discussed. So he may cough. He may say, I am coughing, vomiting, headache, etc. Multiple symptoms will be there. So if so, that means when the patient comes, parents come, they say, my child is also having cough, my child is also having vomiting, my child is also having headache, my child is also having nasal obstruction, many things. Now you ask, out of them, which symptom you think that more disturbing, predominant? So then they may say cough. Okay, so then you understand that cough is the major symptom. Similarly, you can ask which symptom is more. So they may say fever. Then you identify that fever is a major symptom. Okay, fever started first, then cough, so it may be viral. Like that, you have to identify. Now, if they say cough as a major symptom, then it's clear that this is the airway disease. This is a airway disease. So, if main complaint is cough, then ask whether he had the similar episodes in the past also. If he say yes, last 2 months back also he had a similar problem, 5 months back or since birth itself he has got this problem, then it's typical that it's a hyperreactive airway disease. There are many symptoms are there: cough, mild fever, and itching or maybe headache. Many symptoms will be there, but the main symptom will be cough, and patient gives a history that it is repeating. Similar episodes will be there. Then it is a hyperreactive airway disease. There is no fever. Fever is very mild. If it is a hyperreactive airway disease, ask the next question about the family history. So you know that yes, this is definitely hyperreactive airway disease. Now ask the next question. What is that? Family history. Whether somebody in the family is suffering from such problems, okay, or whether there is triggering factors in and around the home. Okay, so though, and also ask the personal history, like infantile eczema, etc. Whether it is that. ಸ್ವಲ್ಪ ಹೊತ್ತು ನಿಲ್ಲು. So if yes, if you find such things, then it's a hyperreactive airway disease due to atopic history. Now, allergy may be atopic and non-atopic. If you find a family history of allergy, then it's first atopic. Okay, now it's atopic. Okay, it's an atopic cough. This is how you have to stream down the allergic disorders. And if there is no family history and child has got repeated attacks of this allergic cough, then it is non-atopic type of allergy. That means allergy is individualized to the child. Okay. Now, in children, this type of allergy is quite common. Now, children's, we actually, the atopic allergies in children is classified in three important groups. One is transient wheezers, and another one is IgE mediated, and another one is atopic. So this particular portion that we will deal in the next class. Thank you very much for patience listening, and don't forget to subscribe my channel, and also please give your valuable comments. We will meet in the next class with the continued portion of the same. Thank you very much.